Hello, this is John Kanellopoulos from our center here in Athens, Greece, the LaserVision Appetary Surgery Center and Clinical Professor of Ophthalmology at NYU Medical School, New York City, New York. This is a very, very interesting case, quite rare in my career. This is a megalocornea. The cornea has diameter over 15 millimeters and has this pellucid-like picture, although it's an oblique cone. We had seen this patient many years. We recommended no eye rubbing, and you can see here how the bulging and thinning of the cornea is mainly inferiorly. The intricacy here is that I opted, instead of doing a penetrating graft, to do what you're seeing here, a circular, annular, peripheral supporting epikeratofakia. And this was a corneoscleral ring left from a penetrating keratoplasty that I trimmed the inner lips and sutured onto the cornea. And you can see how it flattened the cornea, of course, combined with CXL. And now, a year later, cataract has ensued. As you can see here, the technical difficulty here is that I have to incise through my graft here and then through the cornea as well. And I opted to go at the against the rule position because that's where I had the wider view. And this is my paracentesis. The video is ×4, so I apologize for the speed. Same thing here. My paracentesis is just 1 millimeter, and everything else is pretty straightforward. Viscoat in the anterior chamber, a continuous curvilinear capsulorhexis. The visualization is relatively good, and then hydrodissection. We'll appreciate, despite the fact that this lady is just 55 years old, that due to her high myopia, the actual length is almost 30. So if she didn't have keratoconus, she would definitely have very high myopia. So I'm sculpting here the lens. Her refractive error is a -26, but of course part of that is the steepness of the cornea. So divide and conquer technique here. We can all appreciate the density of the lens, and nothing else really of note. And then we'll go in and carefully phaco emulsify each one of the quadrants. I'm going to break and replenish my viscoat around the two residual quadrants and the posterior capsule. Help with my paracentesis, and total 80 joules of energy used with the signature device. We're going to go in and with irrigation aspiration remove the residual cortex. Again, this is a young lady, 55 years old, and the intricacy is that she has keratoconus, very oblique cone. Many people will call this pellucid, but as we saw, this is on the grounds of a very, very large cornea, over 50 millimeter in diameter. And we have performed, and you're seeing it here, a corneoscleral annular supporting epikeratofakia. So we attached this and sutured it onto her cornea, combined with high fluent CXL. After performing a conjunctival peritomy, the conjunctiva was then draped over. Here we're using the Microsoft MA lens at a power of +3. The biometry recommended at -1. And I will place the lens horizontally, remove the viscoelastic. Very careful in keratoconic eyes, and this is a reminder that we need to use miotics because there is always a fear of uveitis Avelio syndrome developing and the iris freezing dilated. So not only we're going to use acetylcholine intraoperatively, we'll see that in a little bit. Now, the intricate thing here is with hydration of the wound is that I have to hydrate two wounds. One is the one of the annular graft, and the other one is the actual host cornea. And it's a little bit tricky. You're going to see me going back and forth. We saw the acetylcholine placed in the anterior chamber and effective meiosis. And here I'm hydrating the actual graft, but then going inner and hydrating her own host cornea, as seen here. And the paracentesis is watertight. The main wound is questionably watertight. And again, the same principle here. So I will finish with a tenonylon mattress suture, try and grasp the corneoscleral annular supporting graft on this oblique keratoconus that we, as you can see, kept the host, the native central cornea, because there was no problem with that, trimming the not burying it in the stromal bed. And we have a perfect case. Patient at the end of the procedure, this was done with peribulbar anesthesia, just 1% xylocaine. All good. Thanks so much for your attention. This is John Kanellopoulos signing out.